Another fine job. I mentioned before something about the gowns. I didn't say anything about those caps, those funny square things you guys were putting on your heads. They also have a symbolic meaning, if you know, and they have that little tassel that comes off the front, right? Right, Professor Lieberman knows. But there's a reason for that, and there's also a technique for what you're supposed to do with it. When you get up on the stage before, or when you entered the hall, before you have been announced and received your certificate and you're now a graduate, you're wearing the tassel on the right side of the point that comes out the front. Once you shake the hand of the department chairman or the ambassador or whoever it was that handed you the diploma, you're now officially a certified graduate, Labuyut. And immediately you take the tassel and pass it to the left side over your heart. And that is the symbolism of that. So the heart, and I want to call now Inbar up to the stage as well.
Okay. Hello, good afternoon. My name is Inbar Kagan-Pearl, and I'm from Israel. I live in a small town, Yehud-Monoson, near Tel Aviv, about 20 kilometers from here, very close to the airport. And I have a little movie about Israel. I would like to present to you my patient. She is 11 years old, medically healthy, fair oral hygiene. She has a slight deviation of her chin to the right and has incompetent lips. When I asked her what is her main complaint, she said, "I cannot close my front teeth, I cannot cut with my front teeth, and I am embarrassed to smile." And when we look at her teeth, we can see that she cannot close her front teeth. Her upper and lower front teeth are not in contact, and there is a 5 millimeters of space between them. This kind of malocclusion is called anterior open bite. Evaluation of the smile. The smile arc is defined as the relationship of the curvature of the incisal edges of the maxillary incisors and canines to the curvature of the lower lip in the posed smile. The ideal smile arc has the maxillary incisal edge curvature parallel to the curvature of the lower lip upon smile. My patient has a reverse smile arc. The arc of the upper teeth does not follow the lower lip. We can see the lower midline 2 millimeters to the right due to functional shift. Regarding her profile, she has convex retrognatic profile. We can see that the chin is retruded in a backward position. There is almost no soft tissue chin. In order to close her mouth, she needs to strain her lips, and we can see a pronounced strain in her lower lip. Facial proportions. According to ideal facial proportions, the face is divided into equal thirds by horizontal lines. We can see that if we will divide her face into horizontal thirds, her lower third of the face is increased. When I asked her for habits, I found out that she is a thumb sucking. Thumb sucking is common when children are infants. Unlike pacifier sucking, that usually stops between 2 to 4 years, digit sucking habits are relatively difficult to break and more detrimental to the development of occlusion. If thumb sucking continues beyond the permanent dentition, it can create permanent dental and skeletal problems and affect the shape of the face. While the finger is between the jaws, the front teeth are pushed forward out of alignment. The result is proclined and protruded upper incisors, extreme overjet, and anterior open bite. We can see in the demonstration the effect of the pressure from the finger. The upper incisors are pushed forward, proclined and protruded, extreme overjet, and anterior open bite, and a narrow maxilla. Thumb sucking can also interfere with the correct formation of certain speech sounds. Depending on the child's age and ability, we need to help the child to stop the habit. In our models, we can impress from the anterior open bite of 5 millimeters from premolar to premolar. There is a cant of the occlusal plane. It inclines to the left due to the position of the thumb in the right side of the palate. The maxillary arch shape is narrow and symmetric. The mandibular arch is round and symmetric. Upper left canine is not in the arch, but we can palpate it and we can notice the tip of the cusp erupting. 2 deciduous molars with amalgam restorations and secondary caries lesions. Upper molars, severe mesiopalatal rotations. The central fossa is not continuing with the adjacent teeth. We have asymmetry between right and left sides. On the right side, she is class 2 full cusp, posterior crossbite. On the left side, molar and canine class 2 half a cusp. The overjet is 6 millimeters and the open bite is 5 millimeters. In the panoramic, the coindal heads are symmetric. We can see that the 3 permanent teeth that are not in the arch will erupt soon. And we can see 3 buds of the wisdom teeth. The cephalometric. According to her cephalometric finding, she is skeletal class 2, retruded mandible, slightly protruded maxilla. She has proclination of upper and lower incisors. We can see a vertical growth pattern. The plane of the lower border of the mandible is steep compared to the cranial base. The lower anterior facial height is increased. And regarding growth evaluation, she is before the peak of growth. These are the initial photos of the patient. We see the anterior open bite of 5 millimeters, increased overjet of 6 millimeters. We can see the AP discrepancy between the right and left side. On the left side, she is full class 2. On the right side, she is class 2 half a cusp. The midlines do not coincide. Her upper arch is narrow, and she has a posterior crossbite. Her upper molar is severely rotated, and she is a high mandibular angle case with increased lower anterior facial height. Regarding her soft tissue, she has convex orthodontic profile, incompetent lips, mentally strained at closure, and obtuse nasolabial angle. So our treatment goals: eliminate the habit, first of all, achieving positive overbite, decrease the overjet, improving the profile, establish proper alignment of the teeth, and achieving class 1 relationship of the molars and canines. This is a demonstration of the result that we want to achieve. So, how we did it? First of all, after a lot of explanations about the consequences of her habit, she stopped sucking her thumb. Second, we wanted an appliance to interfere with the thumb and meanwhile will help us to expand the upper arch, derotate the molars, and even will create a force to intrude them. So it cemented 2 upper bands on the molars connected by a transpalatal arch, far from the palate, in order to interfere with the thumb sucking, and also to control the tongue and to have any effect of intrusion on the molars. Because the molars are mesiopalatally rotated, we activated it to cause molar rotation in the opposite direction, so we managed to derotate the molars and align them in the arch. We can see that the central fossa is continuing with the adjacent teeth, and now we can use a high-pull headgear. High-pull headgear is an extraoral removable appliance that attached to the upper molars and has straps fitting around the patient's heads. The high-pull headgear aids to correct the malocclusion in 3 dimensions. After several months with TPA and the high-pull headgear, rebonded brackets on the upper arch, we can see that the bite is still open, the midlines do not coincide, improvement in the AP relationship on the right, but still class 2 and super class 1 on the left. And you have spaces in the upper arch. We bonded brackets in the lower arch and started with elastics to correct the AP discrepancy and the midlines. We wanted to deepen the bite, so we add anterior vertical elastics called box elastics from the 4 upper incisors to the 4 lower incisors. The force from the elastics pull the incisors and close the bite to create positive overbite. Here we can see it works. This is the elastics from the 4 upper incisors to the 4 lower incisors. Pull the incisors and closing the bite. After wearing the elastics, we can see now the midlines are on. We achieved all our treatment goals, and we decided to debond the brackets. So the results: we closed 5 millimeters of open bite and achieved normal overbite. We decreased the overjet. We established proper alignment of the teeth. Actually, we changed her self-confidence, and you can see it from the glow in her eyes. Her mother called me a few days after the debonding and said that suddenly her daughter started to smile. And for me, it was the best compliment. If we will take a close look at her smile, we will see the harmonious smile, her smile arc that was reversed, now it's ideal. Her profile, she had a retruded chin, almost no soft tissue chin, and now she has a nice chin. She doesn't need to strain her lower lip in order to close her lips. The midlines are on, coincide with the face. She has nice class 1 canons and molars, both sides, and average overbite and overjet. And now she likes us to smile. Okay. This is a special day for all of us. After 3.5 long years, we're all standing here, exciting, seizing the day, and can't believe how fast these years have gone by. I would like to start thanking the orthodontic faculty staff, who accompanied me professionally and shared their knowledge and love of the profession. I would say that the biggest lesson learned was the fact that behind every malocclusion there is a person. I would like to thank my PG family for all the moments that we shared together, professional and personal, special moments that I will cherish forever. And of course, to PG7 and PG9, from my senior, Noah, and from my junior, Omer, thank you. I'd also like to thank my family, my sisters, brothers-in-law, mother and father-in-law, and of course my parents, mom and dad. I wouldn't be in this place without your help and support. You made all this possible for me. Last but not least, I would like to take this opportunity to thank my husband, Hamir. Who always been there for me, supporting and taking the burden in these past 3.5 years. I could have never done this without you. Sorry. I forgot the pictures. This is my parents, and Amir, my husband. And finally, to my 2 superheroes. Thank you all, and good luck.